we'll get started on the webinar, and I'll hand it over to Dr. Michael Fehlings, one of our presenters today.
Thank you, Lindsay, and thank you for everyone for attending this webinar on degenerative cervical myelopathy, which is the most common form of spinal cord impairment in adults worldwide, and likely one of the commonest causes of non-traumatic spinal cord injury. And it's great to have this run through the Circulus SCI Primary Care Network. Reiterate our thanks to the Praxis group, in particular Vanessa Noonan, for their support and sponsorship of this. I'd also like to thank Lindsay Barman and Ruchi Parikh from the Mobility Clinic for their logistical support, as well as Tim Warden and Nadia Jobber from my team at the Toronto Western Hospital and at the University of Toronto. So here we are. I'm doing this in collaboration with Dr. Jamie Milligan, who we can see now. And the idea here is to promote the partnership between neuroscience specialists in primary care physicians to advance knowledge related to degenerative cervical myelopathy. So maybe before we begin, I see that Jamie is solved his little logistical issues. I don't know, Jamie, if you wanted to say a few words before I kind of start with my part of the presentation.
Yeah, no, thanks. Thanks everybody for coming, first and foremost. Again, I'd like to give my thanks to Praxis as well, and Vanessa and our team has set it up. And special thanks to Michael and his team of Tim and Natty as well. It's great to have Michael involved with this project, and he's taking time out of a really busy day and week to do this. So we look forward to hearing from him. With that, maybe we'll just get started. And as Michael said, if there's questions that come up, feel free to put them in the chat, or there will be some discussion at the end.
Great, thank you, Jamie. So we also would like to kind of acknowledge the individuals with lived experience, and it's our hope that this work will facilitate improved diagnosis and care, and ultimately enhance the quality of life of these individuals. So we're going to talk a bit about what is degenerative cervical myelopathy, and a bit about what the current state of the knowledge is. I'll introduce a process that has been led from colleagues at Cambridge University in the UK and the AO Spine International Network. It's called RECODE. And I'll talk a bit about this. This is a knowledge translation process related to DCM. And then I'll hand over to Jamie to talk about why DCM is an important issue for primary care. And then we'll talk a bit about the steering committee, and then we'll kind of go into a question and answer and discussion, and talk about kind of future meetings. So degenerative cervical myelopathy is the most common cause of spinal cord dysfunction in adults worldwide. And it's an overarching a term, and here is an artist's rendering of a schema which kind of combines a variety of pathologies. So in general, these are non-traumatic, benign, non-neoplastic pathologies that result in narrowing of the spine and cause progressive pressure in the spinal cord. The most common type of pathology is degenerative disc disease or cervical spondylosis, but this can have many different phenotypes as well. So there can be, as shown diagrammatically here, instability with retrolucensis causing compression of the cord. There can be a herniated disc. Other types of pathologies can include something called ossification of the posterior longitudinal ligament, which is shown diagrammatically here. This is particularly an issue in individuals from South and East Asia. And then there can also be posterior unbuckling from hypertrophy of the ligamentum flavum. The ligamentum flavum can sometimes be ossified. And so these collectively result in narrowing of the spinal cord and a form of slow motion spinal cord injury. So this is a post-mortem image from Rauschning's collection in Europe, and it beautifully illustrates cervical spondylosis with degenerative disc disease. The disc is very narrowed. There's a compressive pathology and the cord is being squeezed. So we think about the pathophysiology as involving three key factors. So there are static factors. So this is the compression, and this results in ischemic injury to the cord. And then the spine moves, so there are dynamic factors. And so if the spine is deformed, this can cause axial tension. If the spine is unstable, there can be an instability component that worsens this. And there are intrinsic injurious factors that promote a neural degeneration. And these include inflammation as well as ischemia and excitotoxicity, which is a form of nerve cell injury that arises from the activation of a neurotransmitter called glutamate. So patients will present with weakness in the arms or legs. There can be a loss of sensation in the arms or the hands. There can be difficulty with fine motor movements. There can be challenges in balance and walking. There can be bladder and bowel issues, and neck pain can occur as well. Neck pain occurs in about 50% of individuals. And so when it occurs, it's a flag that there may be an issue. And it's important, if patients come to your office with neck pain, that you screen them for myelopathy. But importantly, half of patients who present with cervical myelopathy won't have significant pain. And patients will sometimes not recognize or underreport these issues. So you need to have a high index of suspicion to screen for these. So DCM, again, is the leading cause of spinal cord dysfunction in adults worldwide. It's recognized that most individuals over age 65 will show imaging evidence of cervical degenerative disease. Now, not everyone will get spinal cord compression, but it's estimated that about 1 in 4 people will. So it's a common issue for sure. And there are very substantial costs to society, and there are major costs to the patient, both economically, but also from a health-related quality of life perspective. And patients lose independence, which is important. Now, we lack granular data on the actual costs of DCM, but one can estimate this from the economic impact of an incomplete cervical spinal cord injury in a 50-year-old individual. This is kind of what I've shown here in purple. And you can see that the costs are quite substantial, and they can run into the hundreds of thousands of dollars, and depending on the severity, even over $1 million. And so this can be a very expensive issue. So some of the challenges that we're going to be facing is that with an aging population, and this has been likened to a tsunami, that the prevalence of DCM is anticipated to rise. And so you're going to be seeing more and more late middle-aged people presenting with this complaint. The other challenge is this is poorly recognized both by the general public as well as by the healthcare community. And so patients are often misdiagnosed. So for example, I frequently will see in my practice where patients have bilateral hand dysfunction, and it's misdiagnosed as bilateral carpal tunnel syndrome, whereas the problem is in the cervical cord. And so patients are often being referred when the disease process is fairly progressive. And it's really best to try to pick this up in an earlier phase because the outcomes of treatment will be better. Now, I'll just briefly talk to you about the surgical options, but the important point here is that at one time, surgery was felt to be a last resort, and that the surgery was fraught with hazard and was really probably not in the best interest of the patient always to have this. So this has really changed, and we have excellent surgical options, and the usual outcomes for patients are extremely favorable. And so here's a patient with a multi-level a degenerative disease. There's a kyphotic deformity. The spine is kind of crooked forward. The MRI shows very impressive cord pathology with compression at the disc levels. And one of the solution that I used for this patient was a procedure called a multiple anterior cervical discectomy and fusion. We got a good decompression with an excellent outcome and a very good postoperative course. And then sometimes one can combine this with what's called a corpectomy. So here you take out the whole vertebral body, and then you can replace this here with a cage, or sometimes with an allograft bone and with plate fixation. Then sometimes one may elect to do a posterior approach, particularly with multi-level pathology. And this is usually associated with internal fixation. And again, getting a very good decompression of the cord. And occasionally there are other options. This is what's called a laminoplasty, where you actually open the lamina, and then you then restore the lamina with these little mini plates. And then in patients that have more severe pathology, one needs to combine anterior and posterior techniques. And the evidence has now emerged that surgical treatment is very effective. So this is a study published 8 years ago. It's a large North American trial that I led, and we found very significant improvements on a scale called the Modified Japanese Orthopedic Association scale. So the scores are greatly increased. This is a neck disability index, and so the level of disability is significantly reduced. And this is the SF-36 quality of life score. It's a physical component and the mental component score. And I suspect most of you are familiar with the SF-36 scores. And these are quite dramatically improved. And this was subsequently replicated at an international level, showing very similar results. And so the recent evidence has created a paradigm shift, and where originally it was felt that the best we could do was to halt neurological deterioration. But now most patients have substantial improvement in neurological function with surgery. And it's also now been shown that surgery for DCM is highly cost effective. And this is work done by Chris Whithew, who at that time was a graduate student in my team, and he is now also in independent neurosurgical practice at the University of Toronto. So with this background, we put together for the first time clinical practice guidelines, and these were published 4 years ago in the Global Spine Journal. These are available on open access. And to do this, we used what's called the GRADE process, which is the standard in the field to derive guidelines. And you do high quality systematic reviews, and then one creates a multidisciplinary guidelines group. And I won't go through all of the evidence, but this was the evidence on the effectiveness of surgical intervention. These are what are called forest plots. These are the means and the 95% confidence intervals in black. And these are the different studies that were analyzed. And these are all to the right of midline and markedly so. So the impact of surgery at shorter term follow-up at about a year, intermediate follow-up at 3 years, and then longer term follow-up is very favorable. So we put together this multidisciplinary guidelines group, and this was a photograph of the team meeting in Toronto a few years ago. And I highlighted primary care physicians here who are part of this group, because I really feel that this is a tremendous opportunity to involve primary care to educate patients to recognize this condition and to facilitate referral to specialists. So with this group, we then used this GRADE process. So we look at the best available evidence, we looked at clinical acceptability, we considered patient values, we looked at benefits versus harms and the costs. And from this, we came up with these recommendations. For patients who have very mild impairment, there's probably equipoise between considering the option of surgery, or in cases looking at potentially at structured rehabilitation and a non-operative approach. It partially depends on the patient wishes and in terms of how best to go. And then also sometimes, even though you may feel patients are mild, they will self-perceive that their impact is quite substantial, particularly if they have pain. But patients who have moderate or severe impairment, the recommendation is quite clear that they need surgical interventions. And so here, I've kind of stated this in a different way. So mild cases, depending on patient and physician preference, you have the option to look at this. But it's a good idea to get a surgical opinion in addition in these cases. And then for moderate to severe cases, the standard of care is surgical decompression. And then you need to manage the associated symptoms. And so people can have pain and other issues. And occasionally, if they have very severe impairment, they may have mobility challenges and require assistive devices. So the AO Spine RECODE-DCM project is a knowledge translation effort. And this is spearheaded by these two people, Ben Davies and Mark Cotter at Cambridge University. It's an international working group. And Jamie and I are also part of this working group. And in fact, we had a conference call this morning talking about the development of diagnostic criteria for this condition. So one of the challenges with that the AO Spine group recognized was that there needed to be a unifying term. And the group essentially came to the conclusion that the overarching term that should be used is DCM, or degenerative cervical myelopathy. There was also recognition that we really needed to reach out to the community and to the stakeholders, and to ensure that we were asking the right questions and that we were targeting research in the appropriate areas. There was also an effort underway to come up with a common data elements in what might be a minimum data set, and then to identify the top research priorities. And so this was done through a very rigorous process involving systematic reviews. There were qualitative interviews, there was a Delphi process, surveys, and then item prioritization. And then from this, there's a work underway right now to create this minimum data set, and that work will be coming out in the next few months. And then this slide summarizes the 10 research priorities in the order of importance. So number one is to raise awareness of this condition. Secondly, to look at the natural history of DCM, in particular, patients who present with very mild impairment, because if we can predict which patients are going to go on to have a poor outcome, it will be better to intervene surgically at an earlier stage. And to do this, we need clear diagnostic criteria. And this is what the group was meeting about this morning. And then if patients are going to be monitored, well, we have to figure out what the right approach is to do this. And then we need to look at the biological basis. We need to consider imaging, neurophysiology, and methods to individualize surgery. And then the idea here is to have timely treatment. So we need a collective action. So the RECODE process has interviewed a lot of people in many countries and many specialties to kind of come up with this. In the sense, what we're trying to do now is we're trying to reach out to our collective communities in Canada, and to be very multidisciplinary in nature. This is a shout out to the myelopathy.org group. This is a photograph of a meeting, and myelopathy has actually been deemed to be a national priority in the United Kingdom. And this event coincided with a major event in the British Parliament to recognize cervical myelopathy. So who has a part to play? Well, it's really a multidisciplinary in nature, and we see kind of the people. So we have physical therapists, we have family physicians, we have neurologists, physiatrists, various specialists, rehabilitation specialists, we have surgeons, we have non-operative specialists, including chiropractors, we have researchers, and in addition, we have people from an administration perspective and from a public health perspective. And collectively, if we all come together, I think we can significantly improve the outcomes for people with degenerative cervical myelopathy, reduce impairment, and enhance quality of life. So to talk about the role of primary care in this process, I'm going to hand things over to our co-chair, Dr. Jamie Milligan. Jamie, over to you.
Oh, thanks so much, Dr. Fehlings. That was an excellent overview and look at the work that's being done and will be done. And I'm just going to take it and focus it down into a little bit more into the primary care environment. So I don't have control of the slide, so I wonder if I can ask Michael if you do. Yeah, thanks. So Dr. Fehlings had discussed this tsunami. Probably people have heard about this aging tsunami, or some have referred to it as a silver tsunami. So it's really just a metaphor that's used to describe population aging. But more specifically, it talks about the health and economic implications associated with that population aging. So Dr. Fehlings had showed a previous slide showing how much the cost could be for spinal cord injury and DCM. So this is very applicable to this. But a lot of times when we think about population aging and the health consequences, we think of sort of some of the the big sort of publicity things that are out there, such as dementia, heart failure, heart disease, stroke, frailty, those kinds of things. And not to take anything away from those conditions, but we don't think about things such as spinal cord injury and degenerative cervical myelopathy. And Dr. Fehlings had pointed this out. This can occur in up to 25% of individuals as they age. And as we had said before, it is now the leading cause of spinal cord injury in adults. So many times when most of us probably think of spinal cord injury, we're thinking of usually a younger population that maybe have had some kind of a traumatic injury, motor vehicle accident, or maybe swimming pool accident or something like that. But that is now not the most common cause. It's now the elderly with these degenerative changes. So it's something that we really need to get that into not only the healthcare environment, but also into society. Okay, next slide, please, thanks. So in that realm, it's really important that we talk about DCM and primary care, because it's the most common point of initial contact with those for degenerative cervical myelopathy is the primary care venue. And when we talk about that, we're not talking just about family physicians. We're talking about nurse practitioners and allied health people like chiropractors and physiotherapists and occupational therapists and massage therapists, and potentially talking even about people such as pharmacists who are actually starting to take a bigger role and will take a bigger role as things go on. So it's important that people are aware of this. We've talked about the fact that early diagnosis and management is going to be critical to improve neurological and overall outcomes to prevent further degeneration. But it's hard to impact those types of things when there's limited knowledge and awareness out there. And when I talk, I often talk, about what the situation is like within family medicine, for example. And there is little to zero training on neck type conditions, spinal cord compression, degenerative cervical myelopathy within medical school and even residency. And that is because of, well, in part, there's just, as generalists, there's just so many other things that there's very little time for this to occur. And that is understandable, but it's not proper, especially when we talk about, the way things are going. So that's an area that definitely needs to be improved. Next slide, please. And within all that, so limited awareness and knowledge about it, but there's also a lot of troubles in terms of diagnosing it within the primary care realm or within any aspect of medicine itself. And part of this is that it is a complex and variable condition, as Dr. Fehlings had noted before. With 50, it's a neck condition, and only 50% of people may present with neck pain, which, right away, the variable presentation can be extremely difficult for a lot of practitioners. As Dr. Fehlings had also mentioned, there's a lack of a clear definition. So it's been called by various names before. And whenever anything is called by various names, it makes it hard to really pinpoint it and to create the proper awareness that something deserves. Many cases can also be, quite mild and insidious at onset. So that may lend not only the individual who has symptoms to ignore it or put it off. Let's say if they're starting to have a little bit of tingling in their hands or feet or something. And it also may cause the practitioner, if they do end up seeing them, to also put that off for a while. And there are many mimickers, as Dr. Fehlings pointed out. Carpal tunnel syndrome can be one, but I mean, we can see things like Lou Gehrig's disease, multiple sclerosis, brain tumors, even vitamin B12 deficiencies. Various things can kind of mimic the same types of symptoms. So as mentioned before, you have to have a high level of suspicion for diagnosing this. Next slide, please. So, and the reality of primary care, I'm sure most of us have been there at one point or another, is that it's not really well set up to kind of manage some of these complex conditions at the best of times. So often, 10 to 15 minutes of appointments, and individuals will often present with multiple concerns anyway. So they might a patient may come in, reporting, that they've had a sore throat, but on, their secondary issue, then they may bring up something like this that's very complex and hard to go through. You're also dealing with a lot of competing comorbidities, as I mentioned. So, we're always trying to manage things like heart disease and cholesterol and blood sugars and everything. Then it naturally kind of gets pushed down in priorities. I already talked about the lack of general awareness in terms of training, and once somebody starts to practice, and that we need this high degree of suspicion. And as Dr. Fehlings said, a good place to start sometimes is, if a patient presents with neck pain, you definitely want to ask other questions about what's going on. There is also a lack of patient awareness about things. So in society, this is not a well-known condition. If you do a Google search on, let's say, numbness in your hands, it will not always come up. I had tried that a little while ago. So, other things come up like brain tumors and this sorts of things, but DCM does not always come up in that. And lots of people are doing Google searches. So maybe we need to start raising awareness that way. And then, there's a challenge of, Dr. Fehlings talked about, people with mild symptoms may not always have surgery, but need to be monitored. And how do you do that appropriately in primary care? How do you follow these people in the right way to make sure that they're not deteriorating? That is a challenge within that setting that we need to fix. So one thing that we've come up with the solution before, I've had talks about this, is finding a diagnostic algorithm that fits to a primary care environment, something that all primary care practitioners could do in order to assess this and also monitor this and know when to refer people on. So that's something that's that we're very interested in achieving. Next slide, please. So just, if those weren't enough barriers to things, and there's others that always seem to come up to sort of create some obstacles. So within primary care, even if you make a diagnosis or you think you're a little bit unsure about the management pathway. It's not necessarily so straightforward in terms of how you investigate, how you treat this, how you refer, how you follow up. So there's some systemic issues, such as the lack of specialists. There isn't a Dr. Fehlings in every community, and that's a really big issue. They're actually very, very short supply. So there's wait times and there's often refusal of referrals. And this isn't anything against the neurosurgeons and orthopedic surgeons because they're extremely overwhelmed. But we have to be able to improve that kind of a setting. That's been done in some other conditions. I'll talk about that a little bit later, and perhaps we can draw on that. But even investigating properly, like MRI is the gold standard for making this diagnosis, but that's not easily available. Again, wait times and whether your community has an MRI will really impact and add to that whole length of time before proper diagnosis is made. And in these types of things, we talk a little bit about how health equity should play into things, how healthcare should be equal amongst all. And we had this conversation earlier in our meeting that Michael was talking about. And that's very, very important in a condition like this, where those who are in rural areas and maybe less available of services definitely probably suffer more. And then to add to that, when we talk about, mild degenerative cervical myelopathy and potentially allied health services as being a function or being an appropriate treatment, a lot of people can't afford physiotherapy, for example. They don't have a private health insurance. It's not covered by OHIP. So it's just another barrier to properly being able to manage these. And then overarching to this is really a lack of research funding. The amount of money that's being put into degenerative cervical myelopathy compared to other diagnoses as mentioned before is just minuscule. Okay, next slide, please. So I did just, I talked a little bit about there being some pathways that, have shown promise in primary care, because if you can imagine as well, in primary care with being very general, you're bombarded all the time by various information, that type of thing. But there are some things that work. Down in the bottom there, we look at the stroke face arm speech time, the FAST protocol done by the stroke guidelines, and that's had really good traction. If we look at the top left, we see the Choosing Wisely Canada, which is an endeavor to make sure that we do imaging and lab tests and everything in an evidence-based proper manner rather than just doing all kinds of things for all people and spending a lot of money without getting a lot better information. That's been a campaign that has worked really well. And then down in the bottom left is the rapid access low back pain clinics, which I believe, well, definitely Ontario based. This is a series, this was a pilot project that was initially started in Ontario that looked at trying to streamline low back pain care because it's very costly. Lots of people have low back pain. They're often sent for MRIs when they don't need them. They're often sent to surgeons when they don't necessarily have to be. So in order to cut down on those costs and make sure that the pathway is effective, getting the right people to surgeons, getting the right people to therapies, these clinics have been formed across Ontario where they use advanced practice allied health people to assess and sort of screen them out first, and primary care providers can refer to them. I don't know the stats on them. I don't know the study results of this as of yet, but the fact that the Ministry of Health has continued them shows that there is promise towards that type of a model. Next slide, please. So as Dr. Fehlings had mentioned before, how do we turn up the volume in this? So we need to raise awareness to everyone. So even webinars like this are a great venue to make people aware of this. We need to create some resources for primary care algorithms and screening tools. And we need to create some system change, pathways, improve connectivity and between the various silos of health professionals. And definitely we need further research and funding towards this important condition. Next slide, please. So, and I'll just summarize a little bit on the work to date. As Dr. Fehlings had said, AO Spine RECODE has done a lot of work and has been instrumental in furthering a lot of this. We have formed an Ontario Degenerative Cervical Myelopathy Steering Committee, and probably about 18 months ago, we held a summit in November of 2020, in which we brought together key stakeholders and tried to work out what were the priorities locally based on the AO Spine work that we should look at doing. And from that, there was published an executive summary and a public report. And that steering committee has met monthly since that time, working on projects and goals. And some of that has included presenting at conferences and presentations, such as the International Spinal Cord Society, upcoming at the Family Medicine Forum, which is a large family medicine conference, and at the Spinal Cord Injury Rehabilitation Association conference. Next slide, please. So the DCM steering committee that has formed is really to guide the work of our priorities that were set during our summit. And the top four priorities that we identified from our November 2020 summit was raising awareness, diagnostic criteria, assessment and monitoring, and rehabilitation. And those align with the AO Spine RECODE priorities as well. So that's it from my perspective. We have a lot sort of going on in terms of next steps that we're looking at doing from our steering committee. But at this point, I'll open it up to any questions or comments that anybody has. And I'm not sure if Lindsay's monitoring the chat there.
There's a question in the chat, Jamie and Michael.
Okay, maybe I'll.
Which is, if somebody has had multiple traumas to the neck, e.g. MVAs and whiplash, is DCM more likely?
It's I'll handle that. So this question kind of arises in various contexts, but DCM can be provoked by trauma, particularly if somebody has subclinical cervical spondylosis and then they've had an injury that can then provoke this. If someone is in a situation where they're having repetitive injury, that can potentially cause a disc injury, and then that can subsequently proceed to the development of DCM. Most patients who have DCM do not have a history of prior trauma, but repetitive prior trauma or serious prior trauma can be a potential provoking factor.
Michael, along that lines, can I just ask you as well, because I get this from patients sometimes, is how much of a genetic, or do we know how much of a familial or genetic predisposition is there to this? Because you sometimes will see, I do have two family members, and I mean a short sample size, of course, but I do have two family members who have it, like a mother and a daughter.
Yeah. So it's a good question, and there does appear to be a genetic linkage to this. So we actually just have a paper that came out in Journal of Clinical Investigation where one gene that's been linked to the development of Alzheimer's disease is called the ApoE4 allele. And ApoE4 is a cell surface marker that's linked to inflammation. And if you have ApoE4, you're much more prone to develop Alzheimer's, but you're also much more prone to develop degenerative cervical myelopathy, and your outcomes aren't as good. And so that is a potential kind of familial factor. And certain causes of DCM, for example, ossification of the posterior longitudinal ligament, this does have a very clear genetic linkage. And so this is an area where I would say we're just starting to scratch the surface. But there can be a potential familial component, particularly if you have somebody in your practice, let's say, who's quite young. Say if you have somebody, say 40, and they're coming into your practice with really advanced degenerative disc disease and cervical myelopathy, it would be difficult to ascribe that to aging, right? So that's earlier, and then that does flag the potential that this could be a hereditary condition that is provoking degenerative disc disease and then subsequently DCM.
We have another question in the chat here from Delyn, and she asked, do you see this show up in people with chronic traumatic SCI? If so, are the recommendations the same?
Yes, it can occur. So, for example, people who have a chronic thoracic spinal cord injury, people people put a lot of strain on their shoulders for transfers, and so it's recognized that people can run into shoulder issues, but they can also run into advanced degeneration in the neck, and they need to be screened for the development of DCM. And then also people who have a chronic cervical cord injury, let's say if they've been surgically treated or even not, often will have fused segments in the spine. And as a result, can have additional strain on non-fused discs, and then this can provoke DCM. So it's a good question, and I've actually operated on a number of patients that have been referred to me by my Lyndhurst colleagues in Toronto for DCM who have a chronic a spinal cord injury.
Great, thank you. Are there any other questions for Dr. Fehlings and Dr. Milligan? Oh, I've got another one here from Dylan. What is the percentage of mild symptoms increasing to mod or severe?
Go, Michael.
I was going to deflect that one to you. Maybe we can both kind of address it. So we don't really know an accurate answer to that. So Jamie showed a slide where it shows a broad range, 20 to 60%. So anytime you see that kind of a broad range, it means we don't really know. It certainly is a risk factor. And I think part of the reason that we want to kind of get a handle on the genetics and other type of issues is to get a more accurate handle, on this. So right now we know that patients do need to be followed. Maybe a few clinical pearls would be that older individuals over age 70, let's say, don't tend to tolerate milder degrees of cervical cord compression versus a younger person. It's probably because of the impact on aging. And so I'd be careful to monitor an older individual as they'll tend to not do as well over time. So that's just a little clinical pearl, but this speaks to the point. Maybe Jamie, you can kind of comment on this, but I think this is kind of where the challenge will come in, because there isn't the capacity right now for specialists such as neurosurgeons or spine surgeons to monitor everybody with mild DCM. And so it's going to go back to the family doctors. And so we need kind of an algorithm to kind of to look at these people. It's probably my estimate right now, it was probably about 1 in 4 people within 3 to 5 years will show progression if they've got mild symptoms. And Jamie, if you want to kind of comment further on this from your perspective.
Yeah, no, I think, yeah, that's, you're absolutely right. I think the challenge is monitoring these people in primary care. Even sometimes when you have the right diagnosis and maybe they've seen a specialist, you've done the workup, they've seen a specialist, they've been diagnosed. It's a need to be able to follow them. We lose patients to follow up all the time as well. So, everybody's lives are busy and all this kind of stuff. So, there's just so many factors that go into it. So, not only is the barrier of us knowing what we're doing and being able to be better at that, it's also being able to track people appropriately, give them the right education to know when to come back in or have scheduled times. And there's no real concrete guidelines for that type of thing. So that's something that we need to improve. Everybody needs to be on the same page.
Looks like we've got a few other questions here.
We do. So there's one from Parvin. Does OA cause DCM?
So I'll get at that one perhaps because OA can often affect multiple joints. And so patients who have, say, hip pathology need to be screened for spine pathology. And you'll know that from your practices. It's very common that for people to have a sore back and to have sore hips. But because half of patients with DCM will not complain of neck pain, that's important. You need to just be aware. And so when you're kind of doing your general screening of these patients, particularly if people are saying that they're having difficulty walking, it's helpful to screen people for cervical myelopathy. So doing a Hoffman's test, for example, asking them about hand numbness, hand weakness can be quite helpful. So the answer to that question is an absolute yes. So OA can affect the cervical spine.
I see that Dr. Bauman there kind of has a bit of along the same line. So he works at the Rapid Access Low Back Pain Program Clinic that I was mentioning. He says as part of their lower back assessment and screening test is that they do a Hoffman test and ask about bowel and bladder issues. He's wondering, is there any way we could expand this program to screen for DCM and neck pain? So I guess as you were saying, Michael, definitely those are some good questions, definitely good questions to ask when you're dealing with any sort of spinal issues. Make sure that things up top aren't causing things down below. I guess as well, you know, could some program like that be the Rapid Access Low Back Pain Clinics, could they be adapted to a DCM and neck pain population?
Yeah, I think it's a great question. And I think the answer is yes. And it's you know, we think that you know, patients who are presenting with one type of spine pathology, say low back pain, will often have other areas of spine pathology. And it's estimated that if say people are presenting with lumbar spinal stenosis, about 1 in 4 people will present with cervical myelopathy. So it's common enough that one needs to screen for this. Yes.
Okay. And maybe we can get in one more question there. I see Brandis has a question related to surgery. So after surgical intervention for severe DCM, are there cases where regeneration can occur and any function can return?
Yeah, so it's unlikely that true regeneration of the nerves occurs. So, you know, right now we, as all of you kind of have learned in university and medical school and so on, the nerves in the brain and the spinal cord essentially don't regenerate. There may be a very minimal amount, but they don't. But there is plasticity that can occur. So meaning the sprouting of the nerve fibers can occur. And the relief of compression can result in substantial outcomes. So about 80% of people who have surgery for DCM will improve to some degree. So, and that's kind of where I was alluding to around the paradigm shift. So it used to be thought that, well, you know, the best you can do is maybe to halt the progression. Well, that's a very important outcome, but in fact, most patients get some degree of improvement. And this is, you know, the big appeal to get the diagnosis earlier, because the earlier you intervene, then the better the outcome will be. And then the nuance here then becomes, well, you know, how early is early, and what do you do with the mild patients? But in a sense, that's a good problem to have, because now you've picked it up, you can monitor the patients. If patients show decline, then intervention can occur with a good outcome.
Great. Any final questions? Okay, well, maybe we'll just wrap up by saying thanks again for everybody for attending. That was a great discussion, and thanks for, again, Praxis and our team and Michael and his team for being involved. There will be a webinar evaluation sent out, so we'd ask people to complete that. Also, if you have suggestions for future topics, let us know. If you want to get involved in our network, let us know, contact us. And I think upcoming sort of events, so Lindsay, if you're able to go back a couple slides to, we have a Primary Care Network Summit coming up September 15th. This is a really important meeting that we're holding, open to everybody, that we're really going to be looking at where do we take this network, strategies for the future, planning, that sort of thing. We really encourage people to be a part. We need to hear lots of voices. So you should get an invite to that. I think they went out just recently. And we do have some other webinars coming up. I believe September 22nd is Dr. Lowe is, Eldon Lowe is presenting on neuropathic pain and spinal cord injury, which will be a great topic. He's an expert in that area. So we look forward to that. So thanks once again, Michael. I'll just turn it back to you if you have any final comments.
Thank you. Thank you, Jamie. So just again to thank all of you for attending. Thanks to the Praxis Spinal Cord Institute, Vanessa Noonan and colleagues for their support of this. And it's great to involve the Circulus SCI Primary Care Network. And as you can see from the collaboration that Jamie and I are enjoying, I think this I think this is quite fruitful, and I think it'll enhance quality of care for patients. And I think it'll also facilitate ease of access for your patients that require assessment. And thanks to our local sponsoring organizations, the Mobility Clinic and our University of Toronto Spine program. And we hope to do more of these. We're really interested in your feedback, and then also suggestions around other groups to link with. And so we're really trying to get the message out. And so kind of knowledge translation, knowledge mobilization is a very important component of what we're doing. So thanks again.
Thanks, everybody. Have a good day.
Take care, everybody. Bye-bye. Jamie and team, could